Get started, I'd like to tell you a little bit about them. And so Dr. Liana Billings is an attending endocrinologist and research program director in diabetes at NorthShore University. She's also a clinical professor of medicine on the other side of town at the University of Chicago, although I just heard she mostly has virtual meetings, so she doesn't go there much. Hello? All right. Much better for me. It's hard to hear myself breathe. So she's director of the Personalized Medicine and Diabetes Consultation Clinic, and we're going to ask you a lot of questions about that. So the clinic provides evaluation of monogenic diabetes and atypical forms of diabetes, related genetic testing and genetic counseling. So I'm looking forward to hearing more about your research initiatives, and we'll spend more time talking about sort of the implications for your patient population and innovation. So so maybe I'll have you come first and give your talk, and then I'll introduce Dr. Mark Haupt before he gives his talk. Does that make sense? Great. All right, come on over.
Would you like me to use this? Is this working okay? Touch this? I want this to go. Oh, over there. Okay, thank you for having me. So I'm really happy to be here to share what we're doing at NorthShore as far as diabetes research and personalized medicine. So we'll start with a picture. Many of you may have seen this picture. It comes to no surprise that diabetes is a very big problem, a very common illness in the United States and worldwide. It affects about 25 million Americans, or people with diabetes in the U.S. And this is a heat map showing the U.S. with the highest prevalence being in the southern states, with prevalence up to 15%. But even in the lowest prevalence states, the incidence of diabetes is about 5 to 6%. So still very common everywhere in the U.S. Now, if you take one thing away from this talk, I hope you take away that there are more than 2 types of diabetes. There are many more types than two types of diabetes, but many people only know of 2 types. So you probably have heard of type 2 diabetes, which is the most common form of diabetes. It's a illness that's caused by insulin resistance, so the body doesn't use insulin efficiently, and some insulin deficiency, although people who have type 2 diabetes tend to still make insulin. And insulin, I know I'm speaking to a diverse audience, and insulin is the hormone that lowers blood sugar in the body. Type 1 diabetes is about 5% of all cases of diabetes. It's caused by the immune system attacking the cells in the pancreas, called the beta cells, that produce insulin. And so people with type 1 diabetes are insulin deficient. They do not make insulin, and you have to give them insulin replacement in order to treat the illness. And now I'm going to talk about the last form, or a third form of diabetes called monogenic diabetes. Monogenic diabetes is composed of many different types. So there's Maturity Onset Diabetes of the Young, or MODY, which we're going to talk about primarily during this talk. There's neonatal diabetes, which is diagnosed under the age of 6 months. And there's Wolfram syndrome, mitochondrial mutations, and some other insulin receptor defects that you can't see at the bottom of the slide. But yeah, so these are all different types of monogenic diabetes. So next I'm going to share with you a video of people who have had the correct genetic diagnosis of MODY and how it has impacted their life. And can someone help me start this? Could I just click it? Okay.
form of diabetes that is caused by a genetic alteration in one gene. We know of 13 genes where alterations cause elevated blood sugar. If we know the genetic variation that causes the diabetes, we vary our treatment for that type of diabetes.
I was diagnosed with diabetes in August of 2013, about 24 hours after I had finished an ultramarathon, which I had done before. Usually by the end of the race, I actually could feel stronger, and this time I didn't. I felt weaker and weaker. Right after the race, I went through O'Hare Airport and I couldn't read any of the signs. And I was terrified. I didn't fit the typical profile for a type 2 diabetic, so initially they suspected I might have type 1 diabetes, but I tested negative for the autoimmune antibodies. Then they assumed I was a type 2 diabetic because those were kind of the only two options on the table. My A1C went back up to 8, which is pretty dangerous, and my eyes were getting worse. And Dr. Purdy then referred me to Dr. Liana Billings at the NorthShore Center for Personalized Medicine for further testing. The genetic testing revealed I had MODY diabetes. The diagnosis has changed my treatment plan by informing what medications I need to take. So instead of taking medications for type 2 diabetes, I now take a half a pill of the lowest prescribable dose, and it fixes everything.
It is estimated that 80% of people who actually have MODY are misclassified as having type 1 or type 2 diabetes. In Susie's case, she has a variant in HNF4A, which is one of the more common forms of MODY. Another form of MODY is GCK MODY, which causes an elevated blood sugar that is not toxic to the body.
My name is Amanda Teiser. I'm 27 years old. I work as a physical therapist and as a group exercise instructor. I practice what I preach and live a pretty healthy lifestyle. I went in for a routine health screening we do at work, and I was flagged for a high A1C and high fasting blood sugar. I actually have one of the mildest forms of MODY, so there really isn't any treatment that I'll have to do. Later in life, if I become pregnant, then I might need to go on insulin at that time, but I had no idea this was even a thing out there, and a lot of my coworkers had no idea, so that's very eye-opening, and it's nice to have the opportunity to spread awareness about it.
It's been really amazing. My eyes have gotten better, my energy has gotten better, and I just can't wait to see where this goes now. I finally have hope.
Now you've met Susie and Amanda. You've got a little intro to MODY, and I'm going to talk a little bit in the next few slides, some highlights to take away from that video. But one, what is monogenic diabetes? How does it vary from type 2 diabetes or type 1 diabetes? So monogenic diabetes is a monogenic disease. In contrast to type 1 and type 2 diabetes, which are polygenic diseases, they're complex diseases. So diabetes caused by a monogenic pathophysiology is where there is an alteration in one gene, and that alteration in one gene causes the diabetes. Whereas in type 1 or type 2 diabetes, as far as we understand it, there is genetic variation in many genes, and that genetic burden predisposes you to an increased risk of type 1 or type 2. And more often in more complex diseases or polygenic diseases, there's much more of an environmental component layered on top, whereas with monogenic diabetes, the cause of the diabetes is purely genetic. This is the beta cell, and I'll try to explain this in a simple way. The beta cell, this is a cell membrane, and I want to tell you a little bit about it because most of the genes that we've identified that cause MODY are actually very important in the function of the beta cell. The beta cell is in the pancreas and it makes insulin. And here is the cell membrane. Here on your left is a glucose transporter. When someone eats carbohydrates or sugar, the sugar is absorbed into the blood. This cell senses glucose around it. It's pulled into the cell through this transporter. It's processed by important enzymes, including GCK, which you may have heard Amanda say. Her MODY is called GCK MODY. GCK is very important as far as glucose sensing. Then it goes and makes energy in the Krebs cycle. The energy goes up and closes this channel here. The channel, when it's closed, depolarizes this membrane. So that means that calcium rushes in and insulin rushes out. And that depolarization is really key for insulin to get out of the cell. Then I'll draw your attention down here. So HNF4A, 1A, 1B, and NurOD1 and PDX1 or IPF1. These are genes that encode transcription factors. Transcription factors are needed in order to translate the code of the DNA into a protein. And so patients like Susie had a defect in HNF4A. It makes her less able to translate that DNA into a working insulin molecule. So that's where her genetic defect was affecting insulin production. So there's a very great impact, as you can see, how it impacted those two individual patients of making the right genetic diagnosis. You can use precision medicine. Susie had tried many different drugs prior to the one we ended up putting her on after getting the right genetic diagnosis. So we can really practice precision medicine. We have fewer trial and error, fewer side effects, fewer expense. Quality of life obviously can be improved. The financial burden may be alleviated. It informs whole families. This is a genetic diagnosis, so it affects not many people in the family, and it can clarify our prognosis. So in the case of Amanda with GCK MODY, she, we know in pregnancy she may need to be treated with insulin, but until then she really doesn't need to be treated. She will not develop complications from diabetes even if her blood sugar runs a little higher. So why, if this diagnosis can be so impactful, why are at least 80% of people with MODY actually not diagnosed with MODY? And this is actually an estimate in the UK where they do a lot of the initial research was started for MODY, but it's estimated in the US there could be as high of a 95% undiagnosed rate of MODY. So it's really high even though we know it's there. And why does this happen? Well, the barriers include there's lack of specific screening criteria. It's like we know it's there, but we don't know how to look for it. We think it looks like this, but really the shape is different, the color is different, the size is different. We don't really know how to find it or identify people well that have the disease. We have limited provider awareness. This is a newer discovered, it was discovered, the first genes were discovered in the 80s and 90s, so it's been around a while, but really knowing what the therapeutic implications were, that's much newer in the last 10 years. Now it's starting to infiltrate into the medical school curriculums much more, especially with genetic testing becoming more available. But when I was in med school, I didn't learn about MODY. Really, I had maybe one course on genetics, like pretty minimal. So our next generation of physicians and healthcare providers will know more about this, but the current one really doesn't. Ethnic differences in referral rates. So if someone even knows about MODY, they see someone with a higher ethnic populations with higher rates of diabetes, including Hispanic or African ancestry populations. They tend not to refer because they assume it's just run-of-the-mill type 2 diabetes. When in actuality, we have no reason to think that MODY is not just as prevalent in these other populations. And then the cost of genetic testing has been a huge barrier. About 5 years ago, I tried to send MODY panel with $6,000 out of pocket. Now that has changed a lot, but still there can be unaffordable copays. It's difficult to navigate how to get genetic testing. Providers may not know what genetic tests to send. Providers may not know how to do counseling. How does this impact their employment? How does this impact their life insurance if I actually send this test? So these are some of the barriers as far as being able to get the correct MODY diagnosis. So I'm going to speak to the problem with the screening criteria. So traditionally, we suspect someone who has MODY who has an age of diagnosis equal or under the age of 25, who has at least one parent affected and is not insulin treated. But this only picks up maybe 50% of them. So these criteria are not great at picking up people who have MODY. So we've we've made some adjustments. People who know about this are using some other more specific criteria, but we still really don't know how well this picks it up. We look at people under the age of 35, a normal weighted diagnosis, and who have a parent or child with diabetes. Other features we may look at, they have lack of hypertension or lack of high blood pressure. They don't have high cholesterol, so other metabolic disturbances that you might see in type 2 diabetes would not necessarily be found in MODY. Lack of ketosis at diagnosis, which can happen with someone who's first diagnosed with type 1 diabetes. A lack of diabetes autoantibodies. Autoantibodies are a way of detecting whether someone has type 1 diabetes. They make a protein that destroys the beta cells, and so we can measure that in the blood to see if they're there. And detectable C-peptides. So someone with type 1 diabetes who has destruction of beta cells will not have C-peptide production or very, very low C-peptide production, whereas someone who does not have destruction of the beta cells will actually have C-peptide, so who makes insulin. So these are some of the other criteria we can use to try to detect someone who may have MODY. But then there are researchers who are putting together other things, like what other tools can we use to try to figure out the probability of MODY? And this is published by a group in Exeter in the UK, where they do a lot of MODY research. And it's called the MODY Probability Calculator. It's only been validated in populations until now, but it's an online calculator where you can plug in different clinical characteristics of the patient sitting in front of you, and it will spit out a pretest probability of them actually having MODY. And it's very helpful. In my office, I tend to do this, and I tend to kind of put together their criteria and then a little gestalt, and I figure, okay, I'll send you for MODY testing. So in NorthShore, we're trying to also address a lot of these barriers as far as screening, as far as provider awareness, as far as access to genetic testing. So we've started in one way at the bedside. So we're doing the personalized medicine and consultation clinic in diabetes. And that is a referral clinic. So people, any provider in the community or in NorthShore who suspects that their patient may have in a typical form of diabetes, this doesn't look quite right or feel quite right, they can send that person over and we can do a more thorough evaluation and send genetic testing. And in that, I actually do the genetic counseling and arrange the genetic testing for that individual, and then arrange for follow-up visits in order to provide information to the patient and then their providers on how to handle and what the prognosis of the genetic test result is. And then on the other side is in the research realm, we're doing a study called Find MODY. And the aim of Find MODY is really to address a few barriers. One, we're trying to address the barrier of provider awareness. We want to bypass provider awareness. It's really hard to educate every single provider, and especially in primary care, where they're juggling all sorts of things that are going on to try to, red flag, I see someone in front of me I think might have MODY. It's probably less likely. So that's one of our aims in Find MODY. We're also trying to better clarify what the best screening criteria in a U.S. population will in order to pick up people who actually have MODY. So here are our two aims. I mean, there's more to this study, but mainly in the beginning, demonstrate the feasibility and utility of using the electronic health record to identify people at high probability for having MODY that bypasses the healthcare provider knowledge base, really. And determine the most accurate clinical criteria for MODY screening in a U.S. population by providing genetic testing for individuals identified as high probability through the electronic health record. So can we harness the electronic health record? This graph shows how much electronic health record use has grown in the last 10 years. So this is from 2001 to 2012 across the x-axis, and then percentage of physicians using electronic health records. And you can see the use of electronic health records has grown dramatically, and I'm sure is higher than 70% by now. And at NorthShore, we have a phenomenal electronic health record. We use Epic as our clinical interface, but it downloads into the electronic data warehouse that was established in 2006, primarily for doing clinical quality improvement and applied informatics projects. We have over 2 million people. We have over 4 million healthcare encounters per year, and we have a team of programmers and analysts and physicians and engineers and statisticians and all these people that can help us really understand and make use of these data. So what we did is we built the Find MODY cohort. We started by looking at electronic medical record, and we pulled everyone under the age of 40 who had a diagnosis by ICD-9 code at the time. That was just 2 years ago. ICD-9 code of type 1 or type 2 diabetes. And then we filtered out all the people who had not been seen in the last 2 years at NorthShore. We wanted to get a population that was actually very active in the system. And then we confirmed their type 1 or type 2 diabetes by diagnosis code, and we found about 2,200 people that fulfilled those criteria. So we actually went through and chart reviewed each of these people. A team of us went through and chart reviewed each person to make sure that what we had pulled with the data pull, strictly just using discrete variables, actually was accurate when we actually read what was in the chart. And one of our initial steps in this project is figuring out, well, how accurate is our data pull? I mean, is it possible at some point if we actually have an alert to the physician, say, hey, you better do genetic testing for MODY, based on these clinical criteria that you plugged into the chart, how accurate is that going to be? And we found that it, to a certain degree, is accurate. So we've actually put it into the MODY, that we've screened the Find MODY cohort with multiple different screening criteria. And 2 of the screening criteria we use to try to identify MODY are the traditional criteria, so that's age under 35, normal BMI, and a parent with diabetes. So the data pull identified this gray circle of people within those 2,200 people that appeared to be at high probability of having MODY. And this blue circle is how many people in that, the 2,200 actually were identified by chart review. So it looks like we do pretty well on our data pull. We actually seem to overlap all the people who were identified, nearly all the people identified on the data pull strictly were identified by chart review. But we obviously missed some people. We missed 80 people in there with just data pull. So it's not perfect. And then this is the MODY calculator. So we took that calculator, show you that website from Exeter where we plugged in those data points. Using the data pull, we strictly stuck it in, ran it, and it spit out who was high probability of having MODY. And then we actually went through the chart and made sure those criteria were correct. So it overlapped, 193 patients overlapped both on chart review and data pull. But obviously there are the people who pulled in on MODY calculator that did not seem to be accurately identified, at least according to what was verified in their chart. So actually it's so hard to see, but anyway, this shows the specificity and sensitivity, but the specificity is higher than the sensitivity. The sensitivity was still low. And back to that slide, I think the proof will be, it's an interesting idea how chart review and data pull actually how much they overlap. But the proof will be in the pudding when we actually go and genetically test these people and see if data pull actually would be a feasible means of identifying people when we actually have everyone genetically tested. So I have just 2 more slides. The last point I want to make is, why is understanding a monogenic disease actually important when it only affects maybe 2-3% of everyone with diabetes? Are we really making an impact, just on here or there by really researching these types of diseases? And I would obviously have to argue, yes, it makes a difference. I think it's knowing what the tip of the iceberg really lets us know what's underneath. And I'll give you one example. So this is Lily, and you may have heard about her. She's actually from the Chicagoland area. She is now, I think, 18, 19. She's older than she was in this picture when she was 6 years old. She was diagnosed with diabetes when she was 1 month old. And she was put on insulin she was diagnosed with type 1 diabetes, and she was put on insulin multiple doses a day, many finger sticks or heel sticks when you're a baby. I mean, obviously had a huge impact on her and her family. And until she was 6 years old, she was, on an insulin pump, and she had, many blood sugar checks, and she had hypoglycemic seizures and all of these things, really difficult, diagnosis for her and her family. And so her father was actually at a Juvenile Diabetes Research Foundation meeting and saw Dr. Lou Phillipson speak, who's a researcher at University of Chicago, who's really an excellent MODY researcher now. And he was discussing, happened to just kind of make a comment on a study that was going on in the UK that identified this gene that causes the diabetes in babies under the age of 6 months. And it seems like the people who have this gene can be treated with a pill. So her father went up to Dr. Phillipson and said, I think my daughter has this. And they did genetic testing and they found that she had the alteration in this gene, and they admitted her to the hospital, and they got her off insulin, they put her on a pill, and she now is on one pill twice a day. I mean, a really huge impact on someone's life. And the takeaway from that is actually the neat thing about this is that the pill that actually is being used to treat her is called a sulfonylurea. You may have heard of glimepiride, glipizide, gliclazide. These are some names of this type of medication. It's commonly used in type 2 diabetes. And what it does is what was happening in Lily's case is this channel that's responsible for depolarizing so the insulin can get out of the cell actually is constitutively open. It doesn't close. So she can't depolarize her cell and get that insulin out. She makes a lot of insulin, but she cannot get it out of the cell. So what this medication does is it goes to this channel and it closes it. And it allows her to get all that insulin out. And so this is actually very effective in people with her particular diagnosis, but for type 2 diabetes, it's actually very effective as well. And I think knowing these monogenic diseases, we not only helps us understand how to treat monogenic disease, but also gives us ideas how to treat polygenic disease or disease like type 2 diabetes with medications that can be targeted at these specific genetic mutations. So that's where I'll end, and I think we'll have questions later. Thank you.
Thank you, Dr. Billings. That was wonderful. What a great story to end your talk with. So Dr. Haupt, I'd like to invite you to come here and kind of get ready while I introduce you. And as Dr. Billings said, we'll leave the questions for the Q&A session after this. So Dr. Mark Haupt is an entrepreneur at Matter. He's part of Ariel Precision Medicine, and he'll tell you all about what he does in that capacity. He's also an MD. He completed his residency in general pediatrics at the University of Chicago Medical Center. And after serving an additional year as chief resident, he completed a fellowship in pediatric pulmonary medicine at Lurie. His research focus was cystic fibrosis, specifically examining epidemiological data to evaluate nutritional outcomes. And after completing his training, he joined AbbVie and accelerated from their physician professional development program to a leadership role in the medical affairs division. And now he has become an entrepreneur. So are you going to tell us a little bit? And by the way, he's also he's just about 7 days ago he gave his wife gave birth to a son. So thank you for being here tonight.
Yeah. So if I fall asleep, you'll understand why. Well, thank you, Miriam, for the introduction, and good evening, everyone. And I'd also like to say thank you to NorthShore for inviting us to be a part of this event. As Miriam said, I'm Mark Haupt. I'm the Chief Medical Officer for Ariel Precision Medicine, and I'll tell you a little bit more about Ariel as we get into the presentation and the kind of work that we do. Over the last 2 decades, we've really seen an incredible advancement in our ability to understand the human genome, as well as to study it. And the advances in our ability to study the genome has really impacted our ability to understand the molecular mechanisms of disease, so how diseases work, how they develop. And the 2 major benefits of that in terms of pharmaceutical development, we've been able to identify specific molecular targets to allow us precise medicines for those targets. Additionally, we've been able to advance our ability in terms of predictive mechanisms for disease, understanding disease trajectory, as well as the pharmacogenetic response to that. So as Miriam mentioned a week ago, my wonderful, incredible, beautiful wife who's at home watching, we welcomed our son into the world. And like most new parents, I was up in the middle of the night and I was thinking about this presentation, trying to think about how to frame what the importance of identifying chronic diseases through genetic mechanisms, how to explain that, and what is the context and the importance. And I realized that I was watching this in action. And for those of you who are parents, you may remember the PKU test when you're in the hospital. It's one of the most vivid experiences you have with the newborn. And for those of you that don't have a newborn, it occurs when someone comes into your room and says, I'm going to do the PKU test on your child. And you say, what is the PKU test? Well, every child gets the PKU test. Okay. And then what appears to be the modern form of bloodletting occurs, and that they take blood from your child's heel, seems to go on forever and ever. But this test is incredibly important. And the reason it's important is that it's identifying chronic diseases that with early intervention can have significant impact in reducing complicated outcomes or even mortality. And it's done through measuring biomarkers, which I'll explain a little bit about that as later in the talk. And it's trying to identify diseases that are inherited. And so this is the importance. How do we identify diseases early? How do we identify chronic diseases early? And how do we impact or modify those trajectories? And genetics is a key part to being able to do that. And so in 2014, Francis Collins, who's in the center of the picture here, the director of the NIH, this is actually a picture from 1989 when he helped discover the gene for cystic fibrosis. He said in this interview to the Wall Street Journal that it will soon that we will have the DNA sequence of all infants. And essentially that we'll be entering an era of medicine where it's a lifetime of personalized strategies for disease management, for treatment, and for prevention. And that with biotechnology, with its different mobile devices and whatever it may be, we will essentially have all this information about the quantified self. Interestingly, his predecessor said that by 2030, we'll have the genetic DNA, all the DNA for an infant on a CD-ROM before the time they leave the hospital by 2030. Things have changed just a little bit. And so if we think about these advances in genomics and understanding the genetics of disease, where we've really seen improvements is that in terms of biologic therapies. And if we look in what's available in terms of molecular targets, there are hundreds and hundreds of products that are now available that target specific mechanisms of disease based on genetic processes. And we can think of these, that these are really biologically personalized therapies. I apologize, these slides have changed a little bit. But what we're understanding is that these personalized therapies, the benefits of them, they're obvious. And we've seen these greatest advances in oncology. But tonight we're talking about the role of genetics and genomics, the study of our genes, and personalized medicine in the sense of how do we diagnose these diseases earlier? How do we intervene sooner? How do we change trajectory? And so prior to recent advances in terms of proteomics, the study of proteins, the understanding of genomics, medicine was a reductionist approach. We tried to explain things, to try to explain symptoms, we tried to explain diseases by one gene. And in some cases, there are diseases that can be explained by a mutation in a single gene. For example, Fabry's disease results from mutation in the alpha-galactosidase gene. To essentially cure the disease, you replace the enzyme that was affected by the mutation in that gene. But in some cases, like cystic fibrosis, and this is the protein that's shown here, it's caused by a mutation in a single gene. But there are 2,000 variants that have been identified in that gene, but only 200 are disease-causing. Just because there's a variant present doesn't equal disease. And I think that's an important point to keep in mind, that just because we have a genetic variation doesn't mean we will develop a disease. And I'll explain more. And so if we think about the more common diseases, it's a more complex picture. Genes do not act in isolation. There are complex regulatory pathways that add gene-to-gene interactions. We know there are environmental factors such as the addition of alcohol and tobacco which interact with our genes. We start to think about infectious agents and therapeutic agents, and as you can see, there's this layering that goes on that makes this entangled picture of what's going on in complex diseases. And so as the amount of data surrounding the epidemiology of diseases, in terms of the genetics of it, in terms of the environmental exposures, in terms of the clinical picture, the diagnostic opportunities, the subclassification, the taxonomy of these diseases, the picture becomes less clear. So how do we expect a physician who has, or a provider that has limited time with a patient to be able to digest this information, to take genetic information, clinical information, and put it all together and make a difference in a patient's life? And when that patient asks, why me? What do we do next? How do we explain this? What does it mean for my family? We need to be able to provide tools to both patients and physicians, to really explain what we do next. And so at Ariel, we've decided to take this challenge on, to understand the complexities of chronic disease through their genetic mechanisms, and make a difference through precision medicine initiatives. And the first disease I'm going to talk about, or the disease I'm going to talk about tonight, is pancreatitis. And it's related to the pancreas, so this is a nice talk about the pancreas, and we'll get into a little bit more of that. But before I get into that, I wanted to just highlight 3 types of genomic technologies, just so you're aware of these words. And so you may or may not be familiar with these, but just as a background. So there are 3 kind of advanced genomic technologies that are available. One is what we call a single nucleotide polymorphism array, or SNP array. It gives us the ability to screen the whole genome for millions or thousands or millions of different markers. This is the basis for what we call genome-wide association studies, or GWAS. And basically what GWASs do is they are markers to pinpoint the genetic location of genes that contribute to a particular disease. These are good in terms of diseases that have simple or are fairly not complex genetic basis. But when you start to get chronic diseases, so not monogenic diseases that we talked about, the ability of SNPs to explain those becomes less robust. Array comparative genomic hybridization is essentially looking at duplications or deletions in genes. And finally, next generation sequencing is really this where we're seeing the most advance. And what we're able to see with next generation sequencing is that we're able to do parallel sequencing and using computers to regenerate DNA sequences so we can look at hundreds of different targets and really get into the details of it. It's faster, it's more efficient than previous ways to actually analyze genes. Let's talk about the pancreas. The pancreas essentially has two major functions. One is exocrine pancreas and the other is endocrine pancreas. We've already heard about the endocrine pancreas, which relates to glucose metabolism. Exocrine pancreas is related to digestion. And I'm sorry, these slides have changed. And the exocrine function is related to digestion. So when we eat food, how does it get broken down? And then the endocrine pancreas is related to metabolism. So let's look further into the exocrine pancreas. There are two types of cells that are in the exocrine pancreas. The acinar cells, which are the protein-making cells, which develop the enzymes that are used for our digestion. Those enzymes are developed in an inactive form and have to be transported into the gut through the duct cells, which are highlighted in blue here. The duct cells make a bicarbonate-rich solution, which helps kind of flush the enzymes into the gut. What happens in terms of in pancreatitis, which is the disease that we'll be focusing on, pancreatitis is inflammation of the pancreas. And that inflammation can result from a number of different mechanisms. Essentially, when we think about pancreatitis, it's pain and inflammation in the gut, in the pancreas. Pancreatitis starts as acute pancreatitis, which is a self-limited event, which can resolve over time. Pancreatitis can occur in terms of recurrent acute pancreatitis, so you have more than one episode. But if that inflammatory cascade continues, if you continue to have insult or injury to the pancreas, you develop chronic pancreatitis. And as we can see, it's defined here as a fibroinflammatory syndrome of the pancreas with individuals who have a genetic, environmental, or some other type of pathological response. So basically saying you have to be predisposed to develop this. So there's something in your body that's predisposing your pancreas to developing risk of pancreatitis. And so it's not as simple anymore. Traditionally, when we diagnose chronic pancreatitis, it's diagnosed using imaging mechanisms. And here are a couple of CT scans. And what we see on the left here, this is the pancreas that's highlighted in green. On the left, you see a fairly normal-looking pancreas. But if you look at the one on the right, you see calcifications. There are stones in there. The gland is also shrunken. It's smaller. It's atrophied. Both of these patients had chronic pancreatitis. So we can't rely on these kind of markers to make a diagnosis. So there has to be another way that we intervene earlier and not allow a delayed diagnosis by our reliance on these type of imaging. And so if we think about the patient journey for a typical pancreatitis patient, I'll walk you through this. There are these different stages of disease, and it begins at the at-risk patient who has no symptoms. This could be someone who has a genetic variant that predisposes them to pancreatitis. Something injures the pancreas. It could be trauma, it could be alcohol, it could be tobacco smoke, it could be a medication. It sets them up for an episode of acute pancreatitis. Patients continue to go on to have recurrent episodes of acute pancreatitis. They undergo CT scans, endoscopies to evaluate these. These are expensive workups. And they progress through the different stages going from recurrent acute pancreatitis, early pancreatitis established, and the end-stage pancreatitis. And what you see is that there's a development of these complications the further you go into the disease. Traditionally, chronic pancreatitis is diagnosed late. There is an opportunity to change the outcome of this. So there is an early untapped window for diagnosis and treatment that we need to be able to explore. And so what we're starting to build here, and what I'm trying to explain, is that we're building a model to understand what is the biology and what is the process during which pancreatitis. And this is, again, showing those same stages of pancreatitis that I've mentioned. What we started to understand, there are different pathways within pancreatitis that basically saying there are different flavors of pancreatitis. And those different flavors of pancreatitis are a result of different mechanisms within the organ. Those different mechanisms respond to different therapies. And they're also exacerbated by different environmental factors. And so if we take another step back or even a deeper dive into this, we start to think about different types of biologic pathways that are set up by predisposing genetic factors. We now know there are at least 12 different genes that are associated with the predisposition to pancreatic disease. And the interaction of these different genes with the environment, with each other, is what sets up the risk and drives the disease process. And so now we can understand, based on the actual pathway, the genetics, the overall biology of the individual, we can start to expect what their disease trajectory is. And so as we pull all of this together, we start to create what we call a model. And that model, that mechanistic understanding of this model, is what we've been able to derive from the advances in genetics. And so how do we take this information and then actually make an impact on the disease? And that's through the use of biomarkers. A biomarker is essentially something that you can measure to identify a change. And the importance of biomarkers, which could be blood glucose levels, it could be tumor markers, there are a variety, it could be imaging markers, it could be a genetic test, is that it's something we can follow over time. So if someone has a genetic predisposition to a disease, if we understand the mechanism of their biology and know which biomarkers are associated with that trajectory, we can follow that over time to see when there's a change in that biomarker level or imaging or whatever it may be, to understand when disease is beginning and when we can intervene or if there's a response to therapy. So if we think in terms of this, we can then build predictive models. And basically, we're developing a model to explain things, right? And it also allows us to test things. So imagine if you wanted to make the best cake in the world, right? And you had a bunch of different recipes. You take 100 different recipes. It would take you time and effort to make those 100 different cakes, right? But with modeling and informatics and computers, you can make 1,000 recipes without ever having to make a cake, test all the different components of it, and do it almost instantaneously. And that's what we're doing in terms of predictive modeling. And this is where we start to develop the risk scores, like the MODY risk score that we just learned about. And so how genetic information gets included into these models varies. There's sophisticated mathematical modeling, how we weight the different results of the tests that we have to be able to use this to predict what may happen in disease. And this is from a recent publication that looked at the impact of the addition of genetic information into disease risk scores or risk modifiers. And this is basically looking at, it's on a scale from 0 to 1. This is looking at an area under the curve of a receiver-operator curve, which essentially is that if score is 1, you're able to perfectly discriminate between a patient who has a disease and someone who doesn't. If it's 0.5, it makes no difference. But what you can see in general, the tail is the beginning with a model that does not have the genetic information, and the head of the arrow includes the genetic information. In general, the disease models or the predictions improved when we added genetic information. Clearly, the better your model is, so the higher it is on this scale, the genetic information didn't change it as much because the model was already pretty good. But what you can see is, I think the important part is that adding genetic information into these models adds some sophistication to our understanding and risk prediction. One of the final tools that we're able to use is machine learning. And what machine learning does is it allows us to look into large data sets, the big informatics databases, and develop what are called networks or communities, and basically nodes of information. And we can start to see that there are relationships between either patients. We can look at the relationships between the expression of genes. We can look at the change of expressions of genes over time and start to see how all of these things are connected. And this is really dependent on high quality, both genotypic data, so gene data, as well as clinical data. So if we take an example, perhaps we have a model which we predicted someone to have a certain disease trajectory. In this case, well, this is our patient. It's a blue bubble. Let's say they have a trajectory that we think is going to be slow disease onset. We can use data mining and machine learning to look at networks with other patients who are within the network or databases that we have to see what is their closest relationship. Can we say, are they like other patients who have a slow disease trajectory or a fast one? Can we say, are they going to respond to a therapy or not? Are they going to have an adverse effect to a therapy or not? And so you can start to see how we can build these networks, build these relationships, and understand the different ways of putting this together and understand how genetics plays into these relationships. And so at Ariel, this is what we do. This is what we're trying to accomplish and what we're trying to do with pancreatic diseases. And so we're trying to take the genotype information, the phenotype information, and put it together to provide decision support tools for physicians so they can provide precision medicine solutions to patients. This could be changes in therapy, it could be changes in lifestyle, whatever it may be to change the disease outcome. So how do we do this? So if a physician decides they want to order our test, go online to our website, and this kit gets sent to the patient's home. They never go to the lab. We provide the information, they the kit gets sent to our central lab, where we run a panel of 84 different genes that includes almost 1,700 different genetic markers and targets. And these are the different disease states that we're starting to explore and investigating. We then cluster those panels into more disease-specific panels. So the one that will be available most soon is Pancreas DX. You can see we're also looking at cancer, diabetes, as well as metabolism. We then take that information with our clinical knowledge database, as well as publicly available databases, as well as information that's provided by both the patient and the physician into our electronic portal. We also look at patient-reported outcome measures, as well as the literature database, and we start to look at the interactions between genes to environment, the clinical data, and use modeling, as well as computer learning or machine learning through our SmartMD platform. This is our bioinformatics platform, to develop patient-specific reports that are targeted for that patient to provide. And so I hope what you can see is that the time for including genetics in the disease prediction of chronic disease is now. And certainly there need to be partnerships between academia and industry, as well as federal agencies, to ensure that the information that's being provided to patients and providers is accurate. We want to ensure patient safety. We want to make sure that we're making a positive outcome on patients' lives. So I thank you so much for your attention. I look forward to the discussion after this. I think this is an incredible time in medicine that we're able to changes in the understand what we do. Thank you.
Thank you, Dr. Haupt. So I'd invite you to come and sit on the chairs that are currently not on the podium or on the stage. So while we're waiting for the chairs to be set up, I would invite you to go to matter.socialqa.com and ask your questions and vote on the ones that are already there. And after I'm done with the first set of questions, I'll look there for ones from the audience. So again, it's matter.socialqa.com. Do you want to sit in the middle? All right. So, to start off with, I thought that we would, we have two researchers who also happen to be clinicians. So you've seen discoveries, and what when there's sort of a new genetic test, that's nowhere where it needs to be to prove kind of cost effectiveness. And what does it take to get to that point? And I know you're doing a study. So I'd love to hear, Dr. Billings, maybe first, what does it take to collect enough data to demonstrate clinical utility and cost effectiveness?
I don't think there's one way to figure this out, but the key to cost effectiveness is really if the test is a certain price and the prevalence of the disease is the right price, then something, or the right level, then it'll be cost effective in simple terms. So as far as MODY is concerned, right now we're trying to figure out where do we find these people and what types of populations is it most prevalent. And there has been a study published called the SEARCH study that looked at kids diagnosed with diabetes under the age of 18 who had no autoantibodies to indicate type 1 diabetes and had C-peptide levels that were detectable, so they were making insulin. And all of them were screened actually for the top 3 MODY genes, and the pickup rate was 8%. So the prevalence of MODY among that population was 8%. And it'd be estimated if we get as high as 12% in a population and the genetic testing is under $700, we actually may have a cost-effective test. So it has to do with what population, if you can pick it up at a high enough rate, and the cost of testing.
And I think the question of clinical utility in genetic testing it's really fascinating. So when we think of clinical utility, for whom are we providing clinical utility? Is it the patient? Is it a parent if it's a pediatric patient? Is it for the provider? Is it for the payer? Is it for the system? And so how you demonstrate that in the clinical environment with a new test it's very complex, because how you design the benefit of it to make clinical decisions.
So let's talk about that a little bit. So parents versus payers. So who would pay for these genetic tests? So if we look at sort of NorthShore as an example, do patients mostly pay out of pocket for the tests, or what's
Yeah, I mean,
like a
it
NorthShore?
depends. I mean, so for the MODY in the diabetes consultation clinic, when someone comes to be evaluated and we determine whether they should have genetic testing, we work with a company outside of NorthShore. So I actually don't send the testing through NorthShore. I send it to this company that provides a benefits evaluation up front, so I know what the out-of-pocket cost will be right away, which is a great thing to know, because if it's in thousands of dollars range, it's not feasible for many people. And they also offer financial assistance depending on household income. So that's actually been a really wonderful way that we've broken down a barrier as far as access to genetic testing. Identifying the providers that are willing to provide a service like benefits evaluations and giving us an idea up front of the cost of what the genetic testing will be. But there are other genetic tests that we actually run in-house at NorthShore, or we actually go through our central lab and go out to a different company. And I'm not using those as frequently, but they're all different ways, and we're trying to streamline that more now at NorthShore.
So, Dr. Haupt, since you're an entrepreneur, CMO of Ariel Precision Medicine, what's the path to market for your test?
Right.
Who's going to pay for your test?
So who's going to pay for a test? That is always the challenge. And so if we think about the development of a test, you have to go through a number of steps which are demonstrating the accuracy of the test within the laboratory itself, demonstrating both technical validation, then you have to demonstrate clinical validation, and then clinical utility. And so again, how we get to demonstrating to payers that the test is valuable in the clinical context comes up to your study design. And many tests, unfortunately, in the genetic testing environment are not reimbursed because it's hard to prove that at the time. And we are still in the early stages of our company. We're not commercially available yet. We will be very soon. Looking at our CEO in the audience, hoping it's going to be any day. We're very close. That's some of the discussions and negotiations you have to go through, and be able to provide patients with the support if it's a test that they need to get them access to it, to be creative in the ways that we do this. But again, the hope is that the test will be reimbursed. Our testing there are established CPT codes which are already out there for which we can bill it. But again, that billing and the reimbursement is going to be highly variable and dependent on the for it. As you think about developing a business, how are you prepared to develop that income stream as your test goes to market initially? And that's certainly a struggle, I think, for any company developing a new diagnostic test, particularly in the genomic space.
Thank you. So now we're going to move to sort of clinical workflow and start from the very beginning. So, you run the personalized medicine and diabetes consultation clinic. But the first step is, all right, you have a patient, and maybe not you, maybe a primary care provider at NorthShore has a patient, and something's, they don't think that they truly kind of understand what condition the patient has. And so how do they know that they should refer them to you? Or, how does that work?
Well, we're trying to inform providers in NorthShore and even in the community that we're available. It's hard to know how to reach everyone, but obviously,
And you have to order a genetic test. Which one of the many tests out there do you choose?
So for me, since I'm doing a very specific panel, usually I'm testing one of two panels. So I kind of know what I want to test for. But if say I have someone come in with a different endocrine illness that's not diabetes, and I'm less familiar with the panel, I usually look up on the websites and see what genes I need to order. And I look at the different panels, and I'll order from that particular company, like a kit like you talked about, and we'll send that kit with the appropriate paperwork.
Are there multiple vendors for those two panels?
For the MODY panel and the neonatal diabetes panel, which is the other one that I'll send, yes, there are multiple vendors. So
how did you pick which one to go with? Well, the benefits, right?
Yeah. Well, I looked online at all the different things I could find, via Google, as to who's offering MODY panels and these different genetic panels. I talked to people who had worked with certain companies and made sure the reputation seemed okay. And then I reached out, and actually the company that I work with now actually was very forthcoming and being contacted and working with me on this consultation clinic. So they've made it very straightforward to be able to get the testing for patients. And the out-of-pocket cost for my patients so far has been anywhere from $0 if it's completely covered to $330, which has been the most expensive, which is much less than $6,000 that it was 5 years ago, with a different company. So it really varies quite a lot.
I think that puts the responsibility on those of us who are providing these tests to the communities to really educate what the tests are doing, what's in them, the techniques, because not every panel is alike. There are a number of different pancreatitis panels that are out there, which currently look at anywhere from 1 to 5 genes, but they're all called a pancreatitis panel. And so if you're not familiar with it or understand it, or if it's not clear from the company as to what they're providing, you could get essentially a false negative test because you think you have a negative result because there wasn't a variant in that one gene, whereas instead it could have been in another gene that wasn't investigated. And so that's our responsibility, to educate. And I think in general in the medical community, increasing education about genetics, genetic risk, and variants is a really key part of being able to make genomic medicine successful in clinical practice. Otherwise, it's going to be sitting in the research lab and not ever make an impact for patients.
So which stakeholder in the industry is responsible for that education?
Multiple. I mean, there's so many different avenues, right? And part of it too is just that there's the resources for genetics. I mean, you said you provide your own genetic counseling in your clinic, and you're great that you're able to do that. Not everyone has the sophisticated knowledge to do that. There are genetic counselors. There's a shortage of them. Not every hospital has access to them. And so it's really a multi-pronged approach, from even the basics of medical education, going into medical schools and really making the genetic education more robust there, and residencies, continuing medical education. Those of us who are in the industry side, being able to educate through our websites, through literature, through our studies, working with different organizations and advocacy groups to get information out there about what we're able to offer. So it has to be a multidisciplinary. I don't think there's one stakeholder that can do that.
We have a medical genetics clinic that, there are physicians that had genetics fellowships that have expertise in many different areas as far as genetics. And they're a very good resource for someone like me if I'm coming across something I'm not exactly sure what genes to send or where to go with the panel. I actually reach out to my colleagues there at NorthShore. But there is, if I want to send someone there, there's a lot of time to get there. So NorthShore is really working on implementing a way that every physician can order genetic testing. And we have committees that are trying to help streamline this and say, okay, if I have a physician who wants to order this because of this clinical presentation, they can enter that in our electronic ordering system, and it boom, 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 it just goes with the blood draw. There's not that complicated layer added on. And even things like video consenting and genetic counseling and things like that can be implemented to help with that area.
Cool. So we're going to move to a few questions on social QA. So the first one is, what happens when every human has their DNA sequenced by Watson?
That's kind of opening Pandora's box. I think the question is the technologies and techniques that are available to understand the genome right now are ahead of our clinical understanding. And so that's the concern. And when I mentioned the idea of safety and I think responsible reporting is a key part of this, is that we can't just go out there and willy-nilly say, there are all these variants in someone's genome and good luck. It has to be sophisticated education to the patient, to their family, because that has implications to other members in their family. And we need to have the clinical realm, we need to catch up to the science and understanding these molecular mechanisms. And I think until those are matched, just sequencing everything for the sake of sequencing because we can and because it's affordable and it's accessible, we need to be careful with that. And that day will be coming very soon. I mean, it's there. These analytic companies are there. They're invested in this. They're looking at it. It's a ton of data to be able to explore, and you need the support of those analytics companies to get into that and understand it. But I think we need to be very cautious about how we're doing this, making sure it's appropriate.
But on the other side also, because we are behind exactly in the clinical knowledge, even though the technology is amazing now and much less expensive, it's important to participate in the research studies that now are trying to gain knowledge from all those data. So at NorthShore we have the Genomics Health Initiative where you can actually consent online, and next time you go in for a blood draw, they draw 3 tubes for DNA testing. It's de-identified, and then we can use that to look at 10,000, 100,000 people's genetic variation and see how that correlates with disease risk or how it correlates with response to certain medications, so that we know how to eventually translate all those data clinically into clinically valuable information. So it's really important to participate in those efforts.
Completely agree. And I think the impact of it, as we do understand it, we're able to intervene earlier in chronic diseases, whether it's through therapeutics or lifestyle modification, whatever it may be. It's a huge impact for both the patient, for society, for the healthcare system, if we can really not wait until the end stage outcomes of disease, which may be complex and difficult to manage, versus getting to them sooner. And so it's going to be really amazing to see what happens in the years.
So the next question, for rare diseases with limited patient data, are predictive analytic tools really useful, given the lack of statistical power since you have so few cases?
Well, in our case with MODY, we probably have more cases than we think. So, I mean, as far as probability calculators, I think that if that's what that's referring to, I think it is important to know who to identify so we can actually pick up people who have the illness. So.
And I think that's one of the limitations of rare diseases. That's the data you have to work with. It's an understanding as you're building your models. You have to keep that into the actual statistics and as you're thinking about how you're designing your models and analytics. But using machine learning as well as modeling allows you to study these patients, because if you have the information, you can put them into your model and you can change it without having to have the patients, and allows a way to basically in a computer do some studies. Again, you need to translate to what it looks like in the clinic, but it does provide an opportunity with the caveat that maybe your power is not going to be as good, but that's the reality of rare.
And I wouldn't actually even categorize MODY as rare. It's less common, but if you think of anything that's 2% of 25 million just in the US, it's not rare. So there you go.
There you go. There you go.
There are rarer diseases.
So actually, all of this talk about statistics makes me think like, so you run a genetic counseling clinic, and so you often have data, numbers, statistics, percentages that you have to relate to your patients, and tell them what that means. Can you tell us a little bit about that experience? What works, what doesn't?
Well, so I feel in my case that since I'm doing genetics related to diabetes and the person who's coming to me already has diabetes, it's not like I'm predicting whether they're going to develop it. I'm really trying to diagnose them correctly and get them on the right therapy and diagnose their family members correctly, get them on the right therapy. So I'm not quoting percentages of like, oh, you have this risk of uterine cancer or breast cancer or thyroid cancer. But I think in that setting in our genetics, medical genetics clinic, they're definitely doing more counseling based on those probabilities. And I actually don't really counsel in that way.
Yeah. Do you know how it works and how they might use those numbers? You're right. I mean, it doesn't really make sense for you. You have actual treatment plans that you can.
I mean, I think that as far as cancer genetics, like if someone has the BRCA, mutation, there are prophylactic mastectomies and hysterectomies and interventions that if your probabilities are high enough, you're going to go for pretty significant therapy. So.
Right. So you mentioned that your baby just went through some diagnostics.
Yeah.
Did you talk to a genetic counselor?
No.
Nope.
I mean, we didn't. We did with prior. I mean, you can get genetic screening for cystic fibrosis, for SMA, for a variety of different diseases depending on your ethnicity and your background. And we did at that time with our first pregnancy to look into that. And so when we think about how risk is presented, it's really, you have to be able to present it in a way that's understandable for the person who's in front of you. If you think about like the weather forecast, right? 80% chance of rain doesn't mean it may rain today. Like there's an 80% chance. And saying 60% mortality versus 40% survival, it's two different ways of saying the same thing. And to effectively communicate risk, you have to be able to present it in multiple different ways so that end user of it can absorb it in a way that's appropriate. And it's complex, and it's in being able to have someone understand that, I think it's, again, everyone's responsibility to better educate providers, to better educate the community, articulate that risk in an appropriate way.
I mean, I can tell patients who I diagnose with MODY that their child has a 50% chance of having MODY. So that would be, I guess, a way of predicting. As far as type 2 diabetes, we've actually now identified 80 plus genetic variants that predict risk of developing type 2 diabetes or disturbances in insulin and glucose utilization. But it's been difficult to translate it to the clinic as far as prediction. Studies have actually shown that family history, body weight, cholesterol, all these things we already know may actually be equally as good at predicting diabetes development, type 2 diabetes development. So as a prognostic or as a predictive thing, I don't see genetics as being as big in type 2 diabetes, but as a guide to pharmacology and what we can use to treat diabetes, I think and understanding type 2 diabetes, it's a phenomenal way to figure out how the disease works and how we can best treat it and prevent it.
So the next question, can you comment on services like 23andMe that are more consumer facing, and if that is a valuable tool for the general population?
Yeah, so 23andMe and the direct-to-consumer testing, they use the SNP arrays that I mentioned, and it's looking at thousands to millions of different targets. And those are like, they flag the chromosomes where there may be problems. And so that information is accurate. And it's, there's been an evolution of how they've presented the data and what the requirements are in terms of direct-to-consumer testing and laboratory developments, the development of laboratory-based testing. And certainly, again, it's I haven't done 23andMe, so I don't know what the results look like or how it's presented. But again, it's that communication, and it's the call to action for someone who gets those results to be able to communicate that with their provider, to understand what it means in the context of their whole clinical picture, their family history, as well as what medications they've been on. So it's not just, again, as we mentioned, a variant does not equal disease. The bigger context and picture that I think translating that information and being able to have that communication is what's important.
Can this test be considered part of preventative care? Who would you work with to establish an evidence-based best practice for conducting the test? I guess just genetic tests?
Genetic tests?
Yeah.
It's an interesting question in that if you identify a variant, can you change the patient's lifestyle, their environmental factors, or whatever it may be to perhaps prevent a test? There are some people who believe that that may be the case. Yeah.
So there's a study called at least in diabetes. I only know
Diabetes.
I mean, don't ask me anything else. So in diabetes, there's a study called the Diabetes Prevention Program that enrolled adults who had certain features that showed they were at risk of developing diabetes. And there were interventions that, this is a 3-year trial. They've looked at people 10 years and 15 years, and people are still enrolled and being followed. But the initial interventions were placebo arms, so they just had standard of care, a metformin arm. So they received a very commonly prescribed type 2 diabetes medication called metformin, which is a pill, and then a lifestyle intervention arm where they were randomized to 150 minutes of exercise a week, dietary intervention, and lost about 7% weight loss. Those are the main goals of the lifestyle arm. So I'm part of a genetics working group, and we've looked at how genetics impact that response to that therapy. And certain genetic variations that appear to make you very high risk for type 2 diabetes can actually be negated by lifestyle change or by metformin. So the wonderful thing about that is that even if you carry genetic variation that may increase your risk of an illness, you're not stuck getting that illness. There actually are lifestyle interventions, environmental changes that actually can reduce your risk of progressing to disease. So it gives you hope, rather than you're committed to something you had no control over in the first place. So as far as diabetes, that is true.
And similarly, in pancreatitis, there is a gene, the claudin-2 gene, which in the setting of persistent and significant alcohol consumption is a driver of inflammation within the pancreas. If you don't drink alcohol, the presence of the claudin gene, nothing doesn't happen. It doesn't happen, or nothing occurs. So if you avoid alcohol in those patients, that's a disease modifier right there that you're able to prevent the onset of disease by a lifestyle modification. And so it could be preventative, yes.
So shameless plug on the diabetes prevention side. One of our entrepreneurs, Sindhu Rajan, runs a diabetes prevention program out of Matter. So we have 20 patients coming here every once in a while. So going back to triggers. So what triggers MODY? You heard about alcohol on the.
So that's the key thing with MODY. Nothing triggers it. It's really a genetic defect that causes hyperglycemia. You may get variations as to the degree of hyperglycemia or elevated blood sugar. Like I have a patient who, he has HNF4A MODY. His hemoglobin A1C is 7.5 or 7.4, which is not very elevated. I mean, it's a little elevated, but not very elevated. He has a very, very low carb diet. I mean, nil carbohydrates, no sugar. Exercises a lot. Compared to his sister, who has, a much higher blood sugar in the 8.5 to 9 range without treatment. So the environmental can have an effect on maybe degree, but you're going to have high blood sugar either way. In contrast to type 2 diabetes, where you can have these lifestyle interventions that do, prevent you maybe from developing the illness.
So, Mark, what are the main barriers to creating your predictive models?
It's understanding. I think in terms of predicting modeling, it's taking a reverse engineering approach to get down to the basics of the disease and understanding the specific compartments or mechanisms or things that affect the actual outcome. And so it really gets into how good of an understanding you have of the actual biology, of the molecular biology, as well as the pathophysiology, be able to put those components into a model. So it's not only cell, it's not just proteins, it's the clinical features, and identifying over time and being able to look at what factors actually impact the outcome of disease. And that takes time, it takes experience, it takes patience to be able to understand it, and it's trial and error too. As you start to develop predictive models, you have to test it and see how it works, not only just in terms of using a calculator to see if it works, but looking at patients, so looking at pulling data from data sets and seeing how well does it work retrospectively. So if we take a data set and apply that risk calculator to it and say, okay, this seems to work pretty well, let's follow it prospectively and see how it actually works in the clinic. It takes time, I think, is one of the biggest things too.
So Dr. Billings, there's another question on education, and I think you pretty much answered this, but so it says, how do you educate other doctors and practices about MODY?
Yeah, so mostly it is through lectures or like the patients I showed you with the video. That was published in one of our NorthShore magazines, just reaching out in different ways.
So, so you also mentioned sort of a place for you to find information is often the American Diabetes Association.
Yeah.
Can you tell us what do you go look for there? And
So all these very big societies publish guidelines for physicians. So they have these large committees that review current scientific literature, evidence-based data, good studies, and come up with guidelines for physicians. So it's often helpful for physicians that may not be as an academic institution or are just interested in knowing how best to treat something or how the experts might recommend treating someone. So we'll look at the American Diabetes Association, and they publish guidelines every year on treating diabetes. There's the Endocrine Society that publishes guidelines on other endocrine diseases. The American College of Clinical Endocrinologists is another society that publishes guidelines. And it does help inform people. It depends on how high priority they're going to make something like MODY in their guidelines. And if they're going to highlight it, it's obviously going to reach many more people. I know that it is in the guidelines. There's a couple paragraphs on it, but it's not as explicit as to how to go about getting genetic testing. So I think there still is limits on how much the guidelines can help, but at least they can give people some direction on how best to treat people.
a relevant question that I'll just ask. So if you didn't learn about these rare types of diabetes during residency, how did you become an expert?
Oh, well, I did an endocrinology fellowship.
Helps. Yeah.
Yeah, that helped. I think maybe if I'd gone right into primary care, right into practice after residency, I may not have known about it. I actually do recall, though, a person interested in endocrinology giving a lecture during my residency. So maybe I've been that point, but otherwise,
So, Mark, what's your plan after the pancreas?
We're going to do all things pancreas. So the initial thought for where we're going with Ariel is to start with pancreatitis. That's where our expertise is. That's where our founder, Dave Wickham, is at the University of Pittsburgh Medical Center. That's his expertise, as well as our geneticist at the company. So we'll start with pancreatitis. We're then looking to broaden into diabetes as well as pancreatic cancer. We're looking for funding to be able to do studies in these areas. Then starting to look at other inflammatory disorders, which may include inflammatory bowel disease, perhaps liver, pulmonary fibrosis, and really take what we learned from the models we develop in pancreatitis and expand them to other diseases that have similar pathogenic mechanisms, meaning inflammation. So that's the vision, and we're looking forward to getting there.
There's another question about whether the technology is covered by insurance, and we've sort of covered it, but maybe it's worthwhile to talk about reimbursement and what, how variable is it from one health plan to the next? And, when you think about the patients that go to NorthShore versus the ones that might go to a community hospital, so what does the world look like for them? And
I think that it is very variable. Public aid, Medicaid will not pay for genetic testing. I mean, at least in my experience. Medicare will pay for certain genetic testing. I actually have had one patient get genetic testing for MODY through Medicaid, and I was patting myself on the back. I mean, that was a lot of work, a lot of letters and calling. But it's very variable, and unfortunately, there's discrepancies in who can get the testing and who can't, which doesn't seem fair at all. So I think it's getting better, and I think it's really our job to show how important this is and that it should be paid for, and it can make such an impact on a patient's life, so that these things that insurance companies see that this is really important to pay for.
All right, so we've got a few more minutes left. This one's interesting. So, who owns the results of the genetic tests when they're completed? If the patients own the results, do you provide? So, if the patient do not own the results, do you provide it to them? Or as a startup company that's kind of creating the results, are you planning on doing anything with the data? Do you do aside from demonstrating?
So so it's a great question in terms of who owns their data, right? Patient does. It's their data. It's their information. And so our plan for what we're doing is certainly providing results to both the provider and the patient in a way that's meaningful for both sides of the we're additionally, certainly, as Dr. Billings was saying, we need to do more research. And part of what we're doing is we plan to, as we collect samples, is not only get permission and consent for clinical testing, which we need to be able to do that, as well as for reimbursements, but also getting permission to be able to biobank and store those samples for future research. De-identified, but it's just basically creating biobanks to be able to look into those. And we do intend on doing that, and I think that's a fairly common practice when you get into genomic studies and genetic testing. I think any of the other commercial providers out there are doing very similar things.
But I think what's missing, and you can tell me if this is wrong, but my sense is that you have many different companies that'll do genetic testing, or you'll have researchers doing genetic testing, but there is no central or required repository to put these genetic variants that may be identified. So the thing that you brought up, these VUSs, variants of undetermined significance. So I've had these where I get a report and it says, oh, this person has a variation in a gene. We've never seen it before in our company. We have no idea if this is clinically significant. Here you go. And it's hard to know what to do with those. And actually what I do when I get them is I reach out to my collaborators. Have you seen this in your database? Have you seen this in your database? I look on PubMed, in the literature. Has it been reported in the literature? But there's really not a great central repository, and there should be, and I think it should be required that companies actually put that in there. I don't know what that would take, but so that we can actually, say, the company A found that, 3 of these variants and it's associated with diabetes, and this one found 3 over here, and we can actually conclusively tell you that this is causing your illness. So that's
Yeah, and there are a large number of different collaborative projects, mostly through academia in terms of the 1,000 Genomes Project, a variety of different cancer genome projects, that you can search for these information, but you're right, it doesn't have to be put out there, it should be.
Right.
But I think one of the also additional barriers to that is data interoperability. So how can you have different data systems, companies, and be able to share that data in a way that's efficient, meaningful, and I'm hoping that will change in the next few years so that we can be able to share data in a protected way to be able to look at this and explore it and actually have larger repositories of information so the IBM Watsons can dig through it or appropriately and share and learn more about it. Because if we're not talking about it, if we're not publishing it, no one's going to learn. And so we have to do that. And I think that's where those collaborations between academia, industry, as well as federal agencies needs to be enhanced to improve this communication, improve our understanding, because this is the future and it's here and we need to be talking about it.
So are there any policies and discussion at the governmental level that could enforce this kind of yes? Let's hear it.
Yep.
ClinVar.
ClinVar is part of the 1,000. Yep.
And I heard Heidi Rhyme, who I'm sure you're familiar with, but they are doing a banking program. I just double checked. It was pronounced in October 2015.
Yeah.
And Terry Manalo at the Individualizing Medicine at Mayo mentioned the progress that was made, and that was a session I was at in October of 20.
Yep.
ClinVar I use ClinVar too. We'll look up a variant in ClinVar, but it doesn't have everything. And like, for example, I actually tend to email colleagues in Exeter, and they have like 11,000 people in their database with MODY, and say, did you see this in your database? But they're not necessarily in ClinVar. So it's really fragmented, even worldwide. We're not getting all the information, but it is good. Yeah.
Yes.
Great, thank you. So with that last question, I'd like to thank you both for speaking and for joining me in this discussion. And hopefully you'll stick around for a little bit longer so that if anyone has any additional questions, they can come up to you. Thank you.
Thank you.